Hello, I'm Anthony Hansen. I'm a geriatrician in Cardiff in the trauma unit where I look after patients with hip fracture. Hip fracture is the commonest reason for an older person to need emergency surgery and anaesthesia, and most of us will have friends or family members who have suffered this injury at some stage. Happily, hip fracture care has improved immeasurably in recent years, and so much so that hip fracture surgery is perceived as extremely successful. Surgeons and anaesthetists are increasingly keen to just get on and get the fracture fixed as quickly as possible. And as a geriatrician, I find myself almost getting in the way of that because of the complexity of some of the patients they are wanting to take to theatre. My role as a geriatrician is to deal with the other things that are wrong with the patient and to try and make sure that they don't get in the way of the patient's recovery from their injury. And patients have a lot of things wrong with them. The average age of a patient with hip fracture is 83, and she's likely to have a multiplicity of other conditions. Comprehensive geriatric assessment is what geriatricians bring to the party, and what we do by assessing patients' function, their activities of daily living, their ability to look after themselves, their coexisting medical diseases, their other organ impairments, their psychological and psychiatric cognitive difficulties, is trying to pull all of those together and juggle all of those different challenges alongside the patient's passage through emergency surgery. And on average, patients, if you ask them 50 questions as part of comprehensive geriatric assessment, you'll find that an average patient has about 15 things that are wrong that have implications for their time in hospital. So it's very tempting to let those problems get in the way of orthopaedic surgery, and as a geriatrician, that's sort of what I'm inclined to want to play up the importance of frailty as opposed to the fracture. But that's not the way that I want to approach this brief introduction to hip fracture. Let's view the fracture as the dominant condition, and I'll come back to why that's important a bit later. What does a fracture mean for a patient? Now, a general surgical patient coming in for a laparotomy, an emergency laparotomy, has a whole range of physiological stresses and challenges facing them. But a hip fracture is actually physiologically and pathologically an extremely simple event. Patients bleed. The amount of bleeding associated with the hip fracture is often underestimated. The sort of people we're seeing with a hip fracture will lose as much blood during their time in hospital as many people presenting to the acute medical take with an upper gastrointestinal bleed. So bleeding is important, and you need to think about that when thinking about the immediate resuscitation of the patient. The patient's going to be hypovolemic when they present. However bad their heart is, you still need to put back in the fluid that's missing. They're going to lose the best part of a pint of blood with any of these fractures, and many of them will lose more. And they're going to become dehydrated if they've spent any time on the floor or had any delay in getting to hospital or are spending time waiting for surgery. So there's going to be space for a litre of IV fluids, a litre of IV Hartmann's to go in over the first 2, 3, 4 hours after somebody's first arrives to correct the immediate hypovolemia. But that's probably not going to correct all of the fluid losses that are relevant. And as clinical assessment U&E results come back, it's necessary to then think about the additional fluids you may be needing to give to these patients in getting them ready for theatre. You need to think about how much blood patients will actually have lost. And a hip fracture is not a single disease process. Different hip fractures lead to different blood losses. The difference between an undisplaced intercapsular fracture and a multi-part trochanteric fracture is enormous in terms of blood loss. And as a simple rule, I work on the principle that somebody with the sort of fracture that you might think about screwing is going to lose about a pint of blood in the pre-operative period and another pint of blood during the operative and the post-operative period. So if you look at the drop in hemoglobin from the point of presentation to the point post-op, you're going to see a drop equivalent to 2 units of blood. for somebody having a hemiarthroplasty, a hip replacement, or a sliding hip screw, it's going to be around 3 units on average. And then people who have got a more complex fracture that might be needing a nail, or perhaps have a coexisting coagulopathy, will lose 4 or more pints of blood in the course of their perioperative period. So you need to think about that in trying to work out your perioperative transfusion requirements for these individuals. You also need to think about some things that might make their bleeding worse, and alongside coagulopathy is the role of anticoagulants. Before you do anything about anticoagulation, you need to work out why it's being done. And there's clearly a huge difference between somebody who's on warfarin for lone AF and somebody who has a prosthetic heart valve who would need bridging therapy and a heparin infusion. And patients with recent DVT or pulmonary embolus, patients with a thrombophilic disorder may need thought and discussion of bridging therapy before you reverse their anticoagulation. Reversal of warfarin is necessary. You can't just stop giving warfarin and expect the INR to respond in anything under a couple of days. So reversing warfarin with vitamin K is routine in many units. It's done right from the first point at which patients will present. You need to anticipate that 5 milligrams of intravenous vitamin K will broadly halve people's INR, but only after about 6 hours. And that gives you a sense of how quickly you can be planning repeat blood tests and setting up a timescale for surgery for them. And then the modern direct-acting oral anticoagulants are quite different from warfarin. They shouldn't lead to any abnormality of clotting, and if you see an abnormality of clotting in patients on DOACs, then do wonder whether there might be a coexisting difficulty with coagulation, and think about whether early surgery is necessarily safe. Equally, patients with deranged kidney function, significant chronic kidney disease, may be slower to excrete DOACs. So have a think about those two questions. But in general, the approach in the UK is that surgery goes ahead 24 hours after the last dose of DOACs otherwise. The second physiological consequence of a broken hip is that the patient becomes immobile. Everybody tells me that patients at hip fracture are at high risk of deep vein thrombosis, VTE. What they mean is they're at high relative risk. The absolute risk of symptomatic DVT in our experience is only around 1% for people who are receiving chemical thromboprophylaxis. But PEs are predictable, preventable, and potentially fatal. So we do need to do something about them. Patients expect us to do something, and following NICE's recommendations of chemoprophylaxis for months from admission is really mandatory now. We don't use stockings. We know, and NICE don't recommend stockings because of their potential to cause foot ischemia and pressure sores. Pressure relief is really important from the earliest point in patient's care. If you can't move your leg, you can't shift weight because you've got a broken leg, you're very likely to develop a heel sore. These are horrible, painful, they lead to prolonged time in hospital, they can become infected, can cause absolute catastrophe, and it's difficult to defend their development. So make sure that patients are on pressure relieving equipment in the ED, and make sure that we get them through ED and up to a ward where they're under the care of people specialising in this sort of injury as early as possible into a proper bed. And then if you've broken your hip, you will be incontinent. You can't get to the toilet, you will inevitably be incontinent unless nursing support is structured in such a way to anticipate patients' needs, to meet those needs, to be able to move people appropriately to bedpans, urinals and that sort of thing. It's difficult and it's challenging, and in some ways a catheter sounds a much kinder thing to do to people. They don't have to move. But inevitably, catheter introduces the possibility of an infection. And patients with a catheter in post-op don't need to get up to go to the loo. And getting up to go to the loo, to use the commode, is 2 episodes of transfer practice. It's a key part of rehabilitation. So if a catheter's gone in the perioperative period, get it out as early as possible. And the third, and there are only 3 consequences of hip fracture, is pain. The pain of a hip fracture is instant pain. It hurts when you move. It doesn't necessarily hurt very much if the patient keeps still. You wouldn't let your dentist drill holes in your teeth having given you a little bit of oromorph. You'd want a nerve block, and the patient needs a nerve block. That'll reduce their distress. It gives them a sense that things are fixable. It allows them to move from bed to X-ray to the ward more comfortably. It'll reduce the amount of opiates they need, the risk of opiate toxicity, delirium, and the risk of chest infections. Paracetamol's really important, but it's not going to be enough on its own. We don't use codeine because it's unpredictably metabolized to morphine, so we get on and use morphine for our patients as a PRN and a regular medication in addition to paracetamol. How much morphine to give people is very individual. Every patient is different. Their physiology, their approach, their psychology is different. So what people need is very unpredictable. But by the time most of us ever see somebody with hip fracture, they've already had a test dose of morphine from ambulance staff, from ED staff. So ask them and the staff how they responded to it. Get a sense of whether it was enough, whether it had side effects, how long it reduced pain for. And this process of adjusting PRN and regular morphine doses on a daily basis to match the needs of your patient is a key part of early care. And we don't tend to use oxycodone very much in our patients because it takes 2 nurses to give what is a controlled drug. But in patients with significant renal failure or with cognitive problems and a risk of delirium, oxycodone is cleaner and better tolerated than morphine. So we would think about it for those. And the other aspect of pain control that I find really important is explanation of the fracture, explanation of what's happening, and warning patients of the sort of problems that they need to anticipate. The incident pain of moving a fracture will be radically changed by a nerve block and by surgery. But patients will still have a real sense of bruising around the hip area in the period immediately following surgery, and warning them that this is going to happen and that it's normal, it'll respond to painkillers and that it shouldn't get them up is really important in getting the process of rehabilitation started. The whole point of hip fracture care is to get patients not to theatre, but to get patients up, sitting in front of their lunch the day after their operation, so that they've started the process of recovery. If we can minimise the physiological impact of hemorrhage, immobility and pain in the perioperative period, and these are key aspects of the acute surgical care of hip fracture. If we can minimise the impact of the fracture itself on the patient's physiology and psychology, we can minimise the extent to which the complex pattern of frailties which they will suffer are potentially deranged and decompensated in the immediate post-operative period. If we can stop these decompensating, the patient remains as frail as they were before their fracture. They remain frail. They'll be frail when they go home. But things, if they don't decompensate, these coexisting diseases are just coexisting diseases. They have subtle implications for how you manage the patient, but they don't need to necessarily get in the way. If you don't manage hemorrhage, blood loss, if you don't manage fluid resuscitation, you don't manage their patient's immobility, you don't manage their pain properly, if the surgical team fails to do that, then there's a real risk that the rest of this picture decompensates. The commonest complication of orthopaedic surgery, indeed of any surgery in older people, the commonest complication is delirium. Half of these patients will become delirious if we don't look after these key aspects of early care correctly. If somebody becomes delirious, their risk of dying is twice that of somebody who doesn't. The risk of ending up in an institutional care with long stay in hospital too while that's arranged is quadrupled. So prevention of delirium is fundamental to the management of these patients, but that takes everybody to be involved. I can try and disentangle patients' frailties, the multidisciplinary team, and I can do comprehensive geriatric assessment. The MDT can get them through all of these complex challenges, but it does require that the acute nurses, the acute surgical team, the anaesthetic team take these key aspects of fracture management seriously if we're going to be successful in that. Thank you.